Thank you so much, Rosaline. My name is Smitha, and I work with Professor Amyloid Murphy in Tallaght University Hospital, Dublin. I look after amyloid neuropathy as part of my role, and this is Betsy, my colleague.
Yeah, I'm Betsy. I'm a candidate advanced nurse practitioner, works in the Mater Hospital, work with Professor Rima Joyce, and I look after patients. We have a nurse-led clinic. We have patients with amyloidosis, ATTR, so both patients come to a clinic.
So the idea is that we'll both present very briefly about what we do in clinic, and then the panel's it's open to any questions that you may have. So just to start off with, so I'd like to very briefly go over a patient pathway in clinic, so how the patient progresses through clinic, and a brief outline of the process of applying for treatments, the reimbursement process, and discuss symptoms and the management of symptoms in amyloid neuropathy and our role as a nurse specialist. So when patients are referred on to clinic, they're seen by the consultant for clinical examination, and as you know, there's a key emphasis on family history, just to know is this prevalent in the family or not, and then if there's a good suspicion of amyloidosis, there are blood tests and genetic blood tests involved in helping us figure out is this condition present, and is also then supported by neurophysiology. So in clinic in Tallaght Hospital, we have very limited capacity for same-day nerve conduction studies, and this is a blessing as there's a huge waiting list for this procedure. So we're able to send off some patients straight away from clinic for the nerve conduction studies, and that involves nerve conduction study, QST, pseudoscan, autonomics, a few specialized tests that are coupled along with the nerve conduction study that help us ascertain is there amyloidosis or not. And then following that, as Prof. Rima Joyce and Prof. Sinead Murphy mentioned, we have on a Wednesday afternoon a joint MDT between the neurological team in Tallaght Hospital and the cardiac team in Mater, also joined by hematology specialists or regional neurology specialists or regional cardiac specialists, depending on where the patient is coming from. Now, based on all the test results, if the patient does not present with a neuropathy, we'd progress on with symptomatic management. It doesn't mean they don't have amyloidosis. They would have amyloidosis, but it's just not it's just not confirmed yet on diagnostic tests. So in that case, we'd go ahead with symptomatic management and also refer on to patient support groups. So you'd have heard from MDI who are in the room today. There are patient support group who attends the clinic every Wednesday afternoon, every Wednesday morning, and we'd refer on to them. They're a huge source of support. And if they do have, and also we'd follow them up in clinic every 6 months or as frequently as required. And if they do have neuropathy and say it's diagnosed on the screening test, so say a DPD shows amyloidosis, that's well and fine, we can proceed on. But if it doesn't, we may have to go into skin biopsies, and you'd have heard from Professor Mary Riley yesterday how skin biopsies are very helpful in diagnosing amyloidosis as a confirmatory test for amyloidosis. So if that is there, we can proceed on to applying for reimbursement for these treatments. So yes or no, skin biopsy, it can be done in the skin, in muscles, very rarely nerves, only when required, and fat pad, gastric tissues, and such. Usually in clinic, it's skin biopsy that we do as a new nurse-led initiative. And going into the application for reimbursement of treatment, I'll go into a little bit more detail on the next slide. Following on, a key area of my role is symptomatic management. So like everybody in this room so far has said, keep asking questions, that's how we learn. The more you ask, the more we can support with individual symptoms, and that's how we know you more as well, as a patient-nurse kind of relationship. And also patient support organizations such as the MDI. Once we do have approval of treatments from MMP, and this is a very stringent process, approval isn't always given, though we'd love to have the treatment given to everybody. if approval is in place, we'd commence the patient on the disease-modifying therapy. And this includes subcutaneous vutrisiran. Vutrisiran is initiated at home, and the TCP nurses, who are the counterparts of the Lloyd's nursing group that's prevalent outside Ireland, they initiate the treatment at home and from the first dose itself. And we'd also advise vitamin A supplementation even before the treatment is started. It's just something that we find is always on the lower side once treatment started. So another form of treatment is patisiran, which is the intravenous form, and there's subcutaneous inotersen and oral diflunisal. So these are the available forms of treatment, and we'd link in with the TCP nursing service and follow up the care of this patient. So just to go into a tiny bit of detail about the DMT reimbursement process. So this is also a part of my role in clinic. So the criteria are set by the managed access protocols by the MMP, the Medication Management Program, and the applications are only accepted by approved consultants with expertise in the management of this condition and only from approved centres. So in Ireland, we have 2 centres, Tallaght University Hospital and Cork University Hospital. So the criteria are there should be evidence of stage 1 or 2 polyneuropathy, which is a tool to assess the PND is a tool to assess the neuropathy. Nerve involvement is confirmed through neurophysiology and specific blood tests that they require on the applications, and it should plus or minus, with or without evidence of cardiac involvement. And a few other things that are required are genetic confirmation, echo, DPD, or biopsy, one or the other. If the improvement is in place from medicine's management process, the approval is then sent on to the Access and Integration Drug Management Program, and they write to us saying, your patient has been approved for this treatment, please go ahead and you can order the medication for this patient. And then we liaise with pharmacy, they purchase the drug, and through our agreed protocols, it would reach the patient at their home, and later we'd then apply for reimbursement of this treatment. Each time this treatment is administered, we'd get a report from TCP nursing care, and we can then follow up on how each treatment went ahead for the patient. So that's the general overview of how the treatment is applied for and followed up. Unfortunately, in Ireland, there's just one treatment that's approved at a time. We do not have more than one approved for TTR amyloidosis at one point of time through the MMP. Just to briefly go over the amyloid symptoms, and this has been extensively covered throughout the day, I won't dwell too much on it, but just to go over it very briefly. So this is my key area in focusing on symptom management for patients, and the overall symptoms are, as you know, the early small fiber neuropathy symptoms, which may abate on later on in more advanced stages when large fiber neuropathy and other symptoms come into play. There can be excess sweating and poor temperature regulation, impaired awareness of how your blood glucose is fluctuating. There can be impaired pupil reactivity, so blurred vision when you're changing from light to dark in a room or early in the morning. There can be musculoskeletal symptoms such as carpal tunnel syndrome, which we heard about, lumbar spinal stenosis, which is a very early sign, Popeye sign, which looks like a big muscle, but it's actually a ruptured tendon. And trigger finger, which is locking off the finger. And as you know, it affects nearly every system in the body. So there's multiple autonomic symptoms as well there. Cardiovascular symptoms, orthostatic hypertension, as many of the previous speakers spoke about. It's a drop in blood pressure on standing, and it's very difficult to manage, but it's something that there is help available for and can be managed. Coat hanger pain, which is typically in the back and the neck, in the shape of a hanger, and exercise intolerance, rapid or irregular heartbeats, which can cause dizziness and fainting. The GI autonomic functions were described very, very exceptionally by Dr. Anton Emmanuel yesterday, so I won't go too much into it. But yes, the dry mouth, diarrhea, and constipation alternatingly, and incontinence, nausea, vomiting, early satiety, and associated poor appetite, weight loss. These are all a few things that we'd look out for and try and help with whenever patients have these issues. or even beforehand, just to be aware of them. Genitourinary or autonomic dysfunction, sexual health is something we don't talk about much, but it is a big issue in the condition, and there is help available for these kind of problems and urinary problems as well. So nurses are an excellent source of support. Please do talk to us if you have those problems or anybody you'd like to refer on as well. Managing symptoms is something that we work together with the patient for. So pain management, we have a number of pharmacological treatments available. Chronic neuropathic pain is not easy to face. It could start off with pins and needles. It can be something that's there all the time and never goes away or can come and go. There's a lot of treatments available and not all of them suit everybody, so there's a little bit of leeway to trial something else. If something's not working, don't be afraid to ask, or we can try different things as needed. If those things don't work out, we can go ahead and request the support of pain teams. Physiotherapists are amazing. Occupational therapists are a very good source of support. Psychology also helps, and it takes off the burden of the emotional weight that the patients can have from trialing all of these things and facing all of these symptoms. It's oftentimes a huge area that's unaddressed in the care of these patients. Physios and OTs within the hospital and outside help with mobility aids, splints, orthotics, and other devices that help patients that manage the quality of their life and improve things and get day-to-day things done. So there's help in the technical and device-related areas as well. Feel free to contact us if there's any issues going on. Most of those services are referral-based, so that's the reason we'd be available always if there's anything that's required. Cardiovascular-wise, orthostatic hypertension also has a lot of medication-related supports available, and just a few treatments there, but also other drugs that the patient might be on need to be considered. So it's always looking at the big picture there, as most of our previous speakers mentioned. I won't go into too much of that, but the sensible advice around that is to avoid large meals, avoid alcohol, avoid prolonged standing, lifestyle changes like the previous speaker mentioned, be prepared, pace yourself, those kind of things that become part of your life eventually with this condition. Sleeping with the head of the bed raised. Managing symptoms in the digestive tract. Again, Dr. Anthony Manuel went over this very nicely. So just a few key points. Treatments for nausea, delayed gastric emptying, cramps, diarrhea, constipation. There's a wide range of treatments available, as you all heard yesterday. Bowel training is a key area in the management of gastric symptoms, and this is a very debilitating issue for patients with amyloidosis. So bowel training would involve the correct posture as shown in the picture here with the third person there. So sitting with that 30-degree tilt, lifting up your feet with the help of a stool or something like that, making sure the right time and retraining the bowel to go regularly every day is quite important and quite helpful. If it's a way of life, so retraining your life around these things is probably the biggest thing. Changing your diet, and that is a very tricky situation because of the alternating diarrhea and constipation. And like Dr. Emmanuel said, it would be advisable to go into taking nutritional supplements because they don't give you the wrong kind of fibers, which are hard. They don't require too much fluids to go into your system. It's well balanced, and it makes sure that you're not nutritionally deficient. So nutritional supplements are key there, and dietitians come into play in that area. And do not eat close to bedtime, which is just sensible advice. With regard to bladder, again, sensible advice there. Avoid alcohol, caffeine, spicy foods, pre-bedtime fluids, that kind of thing. Pelvic floor exercises are very, very supportive for bladder weakness. Bladder training and intermittent catheterization are other methods that, if medically advised, you could proceed with. Sexual function is another area that's very affected with this condition. So in women, vaginal lubricants, and in men, there are many treatments available for erectile dysfunction. And I've just outlined a few of the treatments there. So one of the key treatments are the sildenafil or tadalafil, but they have to be used with caution if you have cardiac conditions like ischemic heart disease, because they can cause significant orthostatic hypertension if they're used in association with that. So make sure your doctor knows that you have the heart-associated symptoms as well, or just raise that issue if you do have sildenafil, tadalafil, those kind of medications prescribed. Just ask that question in general. Another option is the prostaglandin E1 analog, alprostadil. They're available in a number of forms, and they're very popular. The intraurethral form and the direct injection both are very beneficial to patients when they require an alternate form of treatment and they have orthostatic hypertension or the first alternative doesn't work. There's also vacuum pump devices, which are very simple and easy to use, like this picture with the black and white pump there. And also surgical treatment where all other available measures haven't worked and you need something else. And there's further research in this area as well. So that's a big area, and there are treatments available for sexual health in women, men, as needed. The key message from that is, sorry, it's very brief and very rushed, but the key message is that there is help available. So on this journey, it's asking questions, and the clinician and the patient, we learn together and explore together the available options. One solution doesn't suit everybody, so that would be the key message in this journey. So the role of the nurse specialist, it's a very new clinic in Tallaght Hospital, year and a half in the working, and our key areas would be symptom management based on what the patient is going through, and joint multidisciplinary team meetings between Mater and Tallaght Hospital and any other regional hospitals that may be involved. I'd be involved with the clinical workup of getting genetic blood tests done, skin biopsies done, applications for reimbursement of the treatment, TCP referrals, and liaising with how the patient's doing on the treatment, and getting the next prescriptions and things like that sorted. Education regarding medication management, dietary recommendations, symptom management for patients, coordinating care with any other specialists who may be involved in the care of these patients, and if there's any new trials coming up, that's another part that we are very actively recruiting towards. So yeah, those are my key areas. Any questions? Thank you. If there's anything that comes up later on, that's my email address, smitha.samuel@tuh. Feel free to contact me. Thank you. I'm just going to hand over